So I guess I'll start already. Can I see everyone really quick? Turn on your videos. 237. 100 plus still not here. Ang dami nyo. Magkakakilala ba kayo lahat? Ang dami nyo. 240. Abutin natin ang 250. Two more. Okay, 250. Okay, so again, good morning. Your session today is on pediatric surgery. I'm Dr. Christine Fausto. I am one of the two pediatric surgeons here in UE. Three na pala kami. May bagong pasok. So, Dr. Abellera will be lecturing to you next week, I think, unless mag-change yung schedule. So the coverage of this morning's lecture is on conditions on head and neck, thoracic conditions, and then your GIT, abdominal wall, and umbilical conditions. So the thing with pediatric surgery is a lot of the conditions that we deal with are congenital. Some of them are acquired. So you find out if it is the differentials that are congenital or are acquired. Congenital mean present since birth, things that develop during fetal development, but do not necessarily present at birth. Yung mga acquired conditions, those are things that develop later on in childhood. There are congenital conditions na ang symptoms nila would only present later on in childhood. So I'll give you examples of that later. So I'll go through certain diseases, not all, because a lot of the diseases that we tackle are rare. So pinili ko lang those that usually come up in the exam, that are must-knows, and then those that are clinically significant with certain embryologic malformations. So not all of these are tackled in your Schwartz. Actually, I do not recommend Schwartz too much for reading on pediatric surgery. There's another book, Ashcraft, that's basic pediatric surgery. Yung Schwartz kasi parang 3 editions na siya na hindi ina-update yung pediatric surgery part. So it's not very, not up to par anymore. So I'll start. So again, parts of my lecture, nawala. Parts of my lecture are
videos. Let me know if you don't see it. Again. Hirap ng keynote. Okay, so the first part, I will be discussing neck masses, congenital pulmonary anomalies, and then your diaphragmatic anomalies, and then esophageal atresia. Hold on. Wow, what are you? Don't use Keynote, guys. Okay, for your neck masses, so the way you can understand neck masses in children is that the differential diagnosis are very different from that in adult. So the masses that you see in adult, pinaka-common, enlarged lymph nodes, and then thyroid, and then tumors. You usually deal with tumors. In the pediatric age group, there are a lot of congenital conditions that present as neck mass later on in childhood na hindi at birth nakikita. So the way that you can identify exactly where the mass came from, you can do it with the help of knowing what the landmarks are through the triangles of the neck. So I think you see this in your books, the anatomic triangles of the neck, bounded by certain muscles or structures along the neck. And then that should give you a clue kung nasang triangle yung mass nag-occur. That should give you a clue what structure probably the mass is coming from. And the most common in children cause for a neck mass is still a enlarged lymph node, or with what we call a lymphadenopathy, a pathology of the lymph node. So in lymph nodes, again, where your lymph drains, you can understand it more by knowing the zones of the neck. So these zones of the neck are the group of nodes around your neck. So you have your group 1, which is your submental, your submandibular, and then you have your jugular chain, your 2B, 3, and then 4, and then the posterior group 5. So why do we group the lymph nodes like this? Because certain groups of lymph nodes drain certain parts of the head and neck. So most commonly, you have an enlarged lymph node presenting as a mass, and this lymph node is just a presentation of a pathology somewhere else in the head and neck, meaning hindi yun yung primary pathology. So it helps that you know where the groups of lymph nodes are, so that, for example, if you have a neck mass in the posterior to your sternocleidomastoid, it's most likely a lymph node. You know that what drains there are the posterior scalp and sometimes your chest or your pulmonary area. So yun yung how you can find out what exactly is going on. That probably that mass is not the primary source, although sometimes it is. So I'll give you the differential diagnosis for your neck masses. So here's a video, introducing to how you should look at neck masses in pediatrics.
A neck mass is a bump or lump on the neck. Neck masses can be present from birth, but usually develop within the first 5 years of your child's life. They are generally painless unless infected. There are 2 types of neck masses: solid or cystic. A solid mass is a dense lump of tissue, while a cystic mass is a sac that fills with fluid. Neck masses can be central, on the front of the neck, or lateral, on the left or right side of the neck.
So that's the way you can look at or assess neck masses in children. You look at where they are located. Is it centrally located or laterally located? And then what triangle of the neck? Or if it appears to be a lymph node, what group of what zone in the neck for your lymph nodes? The other one, if it's solid or cystic, and then when it presents and if it presents with pain. So as the video showed, usually It's only painful if there is an infection going on. So any of these masses can also be secondarily infected, any of these differentials. So the other way you can group these differentials listed here. So again, ito sa right, ito yung mga centrally occurring masses. So kung nasa gitna na yung mass, you already think usually it's dermoid cyst or thyroglossal duct cyst, which are both have a congenital component. If it's lateral to the midline, then it's probably one of these three. Okay, ito yung more common, dito sa left, more common na mga diagnosis. The other way of grouping them is by their pathology. So your inflammatory pathology, again, most common is infection somewhere in the head and neck, and then the lymph node is just reactive to the infection. So if you have an infection of the throat, ears, sinuses, and so on. The congenital conditions, you have dermoid cyst, thyroglossal duct cyst, branchial cleft, and cystic hygroma. I'll discuss them one by one. And then, of course, a mass can be a neoplasm or a tumor. Most common, you have lymphoma. It could be a metastasis from a tumor somewhere else in the head and neck, or teratoma. So these are all more rare. Ang most common sa kanila would be the lymphoma. I won't be discussing so much the neoplasms for this lecture. Okay, so let's go to, as you can see, babies, but it's not very easy to see the triangles of the neck because they hardly have a neck. Yung halos wala pa silang leeg when they're little children. So this is kind of a guide na you can sort of still find yung group of lymph nodes where they occur. So like if you have the lymph nodes in the occipital area, usually may nodule lang, 1 cm nodule in the occipital, papanik si mommy. Ano yung bukol? Ngayon lang yan nakapa. So most likely that's just a lymph node and then it came from an infection somewhere else in the head and neck. Okay, so you have your preauricular, your parotid, submental, and so on and so forth. That's where you palpate for lymph nodes in very, very young children. Okay, so this shows the most common causes. The most common cause of neck mass, again, is in enlarged lymph node, a lymphadenopathy, and usually in children, it is from a secondary infection. So most commonly, you have your common cold, ear infections, scalp infections, throat infections, or tonsillitis, even bronchitis. So even pulmonary can present with a neck mass. So in Filipinos in particular, you don't see it in the books, but particularly in Filipinos, you should consider tuberculosis. Okay, so we are all, as Filipinos, baseline exposed to TB. And then, so TB adenitis or lymphadenopathy secondary to a pulmonary TB is very common in our population. Okay, the next differential you can think of is cystic hygroma, but this one has a very distinct appearance of the mass. So it's cystic, fluid, so very, very fluid, very doughy, alam mong fluid yung laman when you palpate. So it's a fluid-filled sac caused by lymphatic blockage due to a malformation of the lymphatic system. Most commonly, it's in the neck, but it may occur in any other part of the body because our lymphatic system is all over the body. But this may be identified during fetal ultrasound. So even as early as the end of the first trimester, you can already see a neck cystic mass on prenatal ultrasound. And usually it's those kinds that present early during the first trimester. Those are usually the kinds that disappear during gestation. So at birth, wala na, parang nag-flat na siya. That which can occur. But these things, these conditions can also present in a more severe form. So again, it can be identified prenatally. This is usually how it looks like. It's either septated or simple cyst at the posterior neck or a very large na cyst na not very localized. So again, it's a collection of fluid on ultrasound. So the presentations are very, very varied. in across all cases. The most common is that it's identified at birth as like a mass dun sa neck. And then when you palpate it, it's soft, it's non-tender, it's very doughy, there's fluid inside. And usually the parents are just concerned with cosmetic issues in those child. The more severe presentations of these conditions are usually those associated with other genetic syndromes. So the genetic syndromes can be severe enough to even cause fetal death. So like those that occur with heart defects or fetal hydrops, so those are the more severe ones. The next severe one, if it doesn't cause fetal death or it doesn't cause fetal hydrops, can at least cause a mass effect. I'm going to be using that term a lot today. So when we say mass effect, it occupies space that it pushes the adjacent structures aside. So ano ba yung adjacent structures dun sa lateral neck, diba? You have your trachea and then you have your esophagus. So if that gets obstructed, you can imagine hard to breathe, hard to swallow. So that is what we call mass effect. It's not very common with cystic hygroma kasi hindi siya solid. Cystic lang siya. So mass effect is not very prominent in these cases, but it can occur. And then, as I mentioned earlier, the other presentation is they can also just disappear during gestation. At birth, parang may extra skin lang sila sa neck na nagre-resolve na yung cyst. So in other countries, the more severe forms, actually an option is termination of pregnancy. This is not legally an option in our country, but if you're in places like Australia, Singapore, that is something that they do. They terminate pregnancies if they find certain anomalies during prenatal ultrasound. More often than not, if we here in the Philippines find it during prenatal ultrasound, we just plan for delivery, meaning we monitor the cyst if it resolves or if it causes the mass effect, which means that at birth you might expect that you might have to intubate the patient if there might be an obstruction of the airway. But most common, we just do elective surgical excision or sclerotherapy. Sclerotherapy means that we inject a sclerosing agent into the cystic cavity, and then this causes irritation of the lining, which will hopefully absorb the fluid and then will lessen the size of the cyst. So not exactly removing it, pero irritating it enough na mawala yung fluid collection. And this usually requires several sessions of sclerotherapy. So these are the options for those children. We'll go to the differentials for the lateral side of other differentials for lateral neck masses.
A branchial cleft anomaly is an example of a lateral cystic neck mass. These anomalies can present as a cyst, a neck pit with a dead end called a sinus, or a neck pit with an internal opening called a fistula. The branchial cleft system is a series of slits along the side of the neck present during embryonic development. An anomaly means that a part of the system developed differently than expected. There are 4 types of branchial cleft anomalies, but the most common types are second and third. Second branchial anomalies generally reach up toward the tonsils. Third branchial anomalies generally have an external opening in the lower neck and an internal opening in the back of your child's voice box. They most often look like a pit in the skin. Surgical removal is necessary when the cyst, sinus, or fistula begins to drain, becomes inflamed, or forms an abscess. The surgery happens in an operating room. When the anomaly is a bump, your child surgeon will make a small cut across the bump. Once inside, your child surgeon will lift up the muscles in the neck to reveal the anomaly and remove it. When the anomaly shows as a pit in the skin, An oval-shaped cut is made around the pit. Multiple cuts may be needed. Once inside, your child's surgeon will use their airway, voice box, and neck muscles to help locate the anomaly and remove it. The wound is then closed with stitches that are hidden under the skin and don't need to be removed.
Okay, so this slide summarizes the types of branchial cleft cysts that we have. So as the video showed, it is a remnant of something that should have was resorbed during fetal development. So kung may remnants of your branchial pouches, it can leave our lumen dun sa tract that where where fluid can accumulate. So they usually have a remnant connection with their previous connections during fetal development. So most common, the branchial cleft cyst has a tract still connected to your palatine tonsils. So remember that. Memorize this table, guys. So most common, second branchial cleft connected to your palatine tonsils. The second most common, the third branchial cleft, usually has a connection to your thyrohyoid membrane or your piriform recess. Review your head and neck anatomy. So lesser common, you have your first branchial cleft. Usually you see, some of you might have it. If you have a pit here in front of the ear, in the preauricular area, if you just have that dot, yung parang may pore, basta may pit. So that's a remnant of the branchial cleft. So again, these things are not, so that one's connected to the preauricular area or your parotid gland. And then rare fourth is the one connected to the thyroid or the supraparathyroid sa neck. So again, these things don't usually need any treatment unless it starts draining, it starts infecting because of that connection. So you can imagine pag every time may tonsil infection, pwedeng mag-infect yun. So if it infects, if it drains, if there is an actual mass or enlargement of the cyst. So those are usually the reasons we remove these cysts. Let's go to the next differential. So those are your laterally occurring neck masses. Let's now go to the centrally occurring.
A dermoid cyst is an example of a central, solid neck mass. The cyst is present from birth and develops slowly. A dermoid cyst forms in the developing embryo when tissue layers do not travel to the correct areas. This traps tissues that are typically found on the outside of the body, like skin, hair, sweat, and oil glands, on the inside of the body. The cyst rests just under the skin and on top of the muscles in the neck. The cyst will continue to grow if not surgically removed, so removing it earlier in its development makes for a smaller surgery.
So again, your dermoid cysts are inclusion cysts. So what we see there when we excise these on histopathology are remnants of dermal tissues. You have epidermis, you sometimes have hair follicles and things like that. So these are benign conditions, but of course they look weird and they enlarge as the child grows. They enlarge with the child, so it gets worrisome for parents. So we remove them while they're still small. Surgical management is simple excision of the mass. Akala ni Siri kinakausap ko siya.
A thyroglossal duct cyst is an example of a central cystic neck mass. This type of cyst grows from the structures that form the thyroid gland, an organ in the neck that helps control metabolism. During fetal development, the thyroid gland travels down the neck from the back of the tongue, forming an open path called a tract. This tract closes during development, but can remain open in some children. a pocket of fluid can grow if the tract stays open. This is the cyst. Your child's doctor can diagnose a thyroglossal duct cyst by asking them to stick out their tongue, which causes the cyst to move up and down. The diagnosis is confirmed using ultrasound or other imaging methods. The cyst can be removed with surgery if it becomes infected, is draining, to decrease the risk of thyroid cancer from developing in the cyst, or because you may not like how it looks. The surgery happens in an operating room. Your child surgeon will make a small cut in the skin along a fold in the neck to help hide any scarring that may develop. Once inside, the surgeon will find the cyst, which can be stuck to the bottom of a small bone in the neck called the hyoid bone. The hyoid bone and cyst are dissected free from the neck muscles. The middle of the hyoid bone is cut and removed along with the attached cyst. The wound is then closed with stitches that are hidden under the skin and don't need to be removed.
Okay, so much like your branchial cleft cyst, your thyroglossal duct cyst, we shouldn't do a simple excision because of the tract. So if we leave the tract behind, then usually the cyst will occur. So that's what's similar between your thyroglossal and your branchial cleft cyst. You need to remove the tract with the cyst. So in cases of thyroglossal duct cyst, this usually involves removing that middle portion of the hyoid bone because that's where the tract is usually attached. So we call that the cystroc procedure. I'm sorry. What? So this again is centrally occurring, and then it's the mass is centrally occurring, and the procedure that involves removal of the cyst along with the tract and the central portion of the hyoid bone is called the cystroc procedure. Okay, so I think, did I cover everything? We covered everything on head and neck. Do we have any questions? I will not go into the neoplasms anymore. This is the less common, not exactly a mass. It may appear as a mass, but it's just a fibrous proliferation of the sternocleidomastoid muscle. So we call it the fibromatosis coli. So this is one of the most common causes of torticollis. If you know torticollis, it's the deviation of the turning of the neck of newborns, and then they usually resolve spontaneously. So not exactly a mass, but it may appear as a mass, and they require surgery. So you can determine that this is actually fibromatosis if you do an ultrasound and there's just the enlargement of your sternocleidomastoid. No questions? So far, we're good? Yeah? Okay. So let's go to your congenital pulmonary airway malformation and your bronchopulmonary sequestration. These are the two conditions we will discuss under pulmonary anomalies. So the first, your CPAM. We call it CPAM. In older books, in your books, I'm not sure, it used to be called congenital cystic adenomatoid malformation. So if you come across that, it's the same as CPAM. So now it's called congenital pulmonary airway malformation. So it is a lung formation. You can see it from the word. It's congenital. It involves the lung. It's a malformation. And it involves the airway. So that's what's important there. It's a pulmonary congenital malformation involving the airway, as opposed to the next condition later, it does not involve the airway. Usually these affect you only one lobe in one of the lungs. So they form during fetal development, it's congenital, and it's continuous with the airway. So they present as cysts, yung malformations. They are fluid filled in utero, but once the child breathes air, once the child is born, since these cysts are connected to the airway, it gets filled up with air at birth. So that's usually where the symptoms will come from when they start breathing. Congenital CPAM is the cause for these are unknown still, pero the theories are that either they are developmental failures or it is a type of hamartoma, which is a benign kind of sort of tumor, an overgrowth of lung tissue. It can present as pulmonary hypoplasia in more severe cases because they can cause mass effect where the malformation pushes the other structures, adjacent structures like your heart or large veins. Excuse me. So this causes the blood to back up on your fetal veins, and the fluid can leak into your other fetal tissues. So in those cases, it can cause fetal hydrops, and this can be actually severe and cause fetal death. So it depends on the size of the cyst and the location of the cyst if the patient will be symptomatic and how severe the symptoms would be. So there are several types, 0 to 4, and then the types would depend on where the cysts occur. So the first type, subtype 0, it's very rare. If it's rare because we don't identify them enough because these are usually fatal and difficult to see on prenatal ultrasound. So they occur in the trachea. So you can imagine if it's in the main airway, there is no air that can come in when the patient is born. So this obstructs the main airway, so it becomes lethal. It's very rare. The most common is type 1, which is it's located at the distal bronchi. It usually presents as one or more large cysts, and these may not present at all, so they may not be symptomatic, and but they may also cause respiratory distress at birth or recurrent infections kasi nga they are connected to the airway. Type 2 is in your terminal bronchioles. These ones are sponge-like in appearance. They usually present during the first month of life. And these are the ones that are usually associated with other anomalies in the thorax, like your diaphragmatic anomalies, cardiovascular, and then renal anomalies. Type 3 is near the alveolus. These look like, because they are in the smaller parts of the lung, they look kind of like a mass, or they are adenomatoid in appearance. So these can also present with severe neonatal respiratory distress because your alveoli can't the absorption of the oxygen is impaired. The last type 4, they occur in the alveoli. These ones can present at birth or up to 6 years of age even. So in older children, pwedeng dun pa yung presentation and not identified at birth. They can cause respiratory distress, they can cause pneumothorax, infections, or they may be just incidental findings on your chest x-ray. So the reason for these symptoms, again, is from that connection in the airway. So if there's air that goes in the cyst can rupture, and the cyst can impair oxygenation. So if they're really small, insignificant, patients may be asymptomatic, but they can, as mentioned earlier, they can also be large enough to cause a mass effect and cause pulmonary hypoplasia. When I say hypoplasia, it means the lungs did not develop. So parang during fetal development, kung may something obstructing the lungs from developing, so the lungs won't develop at all because of that mass effect. So this can cause respiratory distress at birth when the patient is no longer relying on the mother for oxygenation. Once they cry and air comes in, and then there is no lung to fill up with air, so it will cause respiratory distress at birth. Because of that airway connection, it can cause recurrent infection. Pwedeng pumutok yung cyst and cause pneumothorax, and also some of these conditions are associated with forms of lung cancer. So prenatal diagnosis is possible. Some of really large cysts can be seen on prenatal ultrasound, but most commonly we identify these cases postnatally. initially through chest x-ray. They may appear as cystic structures on chest x-ray and then more specifically identified by chest CT scan. So again, the range of presentation is varied. They can grow, they can stay the same size, or they can even disappear, egress during pregnancy. There are options for prenatal management. I don't think we do this yet in the Philippines, fetal surgery, specifically for CPAP. So we've done fetal surgery in the Philippines. I think St. Luke's and TMC has had cases, but not yet for CPAM, I think. The other option is at birth, we do what we call exit procedure, ex utero intrapartum procedure, which means that at birth, hindi muna tinatanggal yung connection sa umbilical cord. So while the mother is still supplying oxygen to the baby, we do intervention for airway for the child. Most cases, they undergo, for those that are not that severe, like it doesn't impair oxygenation or the airway, surgery can be done by lobectomy, removing that affected lobe of the lung. So the next condition is the bronchopulmonary sequestration. So this one, as opposed to CPAM, this one presents as a largely solid condition, not cystic. So cystic si CPAM, solid si bronchopulmonary sequestration. It's easy to remember. So this one lacks that connection to your airway, to the tracheobronchial tree. And usually they present with an anomalous blood supply from the systemic circulation. So usually pag na-CT scan sila, merong artery, may aberrant artery from the aorta going straight to a mass inside the thorax. So this is also a parenchymal maldevelopment of the lungs. There are two types. You have your intralobar, which means that the lesions are contained within the investing pleura of the lung. So those usually are in the lower lobes, and they are more common in the left lung. And then you have your extralobar, which is the lesions that are outside of the investing pleura of your lungs. Many of these cases are actually asymptomatic because they don't have that connection to the airway. So they don't cause as much respiratory distress as your CPAM. But some of them can present with recurrent infection if there's hematogenous seeding from that aberrant blood supply. But most of them are just incidental findings of a mass on X-ray or CT scan. But these cases are usually more associated with other anomalies. 50 to 60% of them have other thoracic anomalies, like your congenital diaphragmatic hernia, diaphragmatic eventration, or your other foregut malformations, which is the next one that I will be discussing with you. So as you can imagine, it's a solid mass in the thorax. So an X-ray, it appears as an opacified solid lung mass. Sometimes it can be cystic with an air fluid level. That's a more rare case if it's infected. So this is how it would appear on chest CT scan. You see that aberrant blood supply and then a solid structure inside or outside of the pleura of the lung in the same side. So surgical removal of the mass, like lobectomy, sometimes may also be needed. Do you have questions so far? Okay, just interrupt me if you do, okay? We have a lot of other conditions.
Congenital diaphragmatic hernia, or CDH, is a birth defect that allows abdominal organs to pass through the diaphragm, enter the chest, and inhibit lung growth. This can cause breathing problems after birth. Let's take a closer look at the hernia. The chest is separated from the abdomen by a thin muscle called the diaphragm. Sometimes very early in fetal development, the diaphragm fails to completely form. This can cause some of the organs in the abdomen, such as the small intestine, stomach, or liver, to move into the chest cavity. These organs press against the lungs, slowing down the lungs' development as the rest of the body continues to grow. This can cause two main complications: pulmonary hypoplasia and pulmonary hypertension. The first is the degree of pulmonary hypoplasia, or small lungs. During breathing, air travels down the windpipe into the lungs and is sent to small air sacs called alveoli. Once inside the alveoli, oxygen is absorbed into the blood through the surrounding blood vessels. The blood changes from blue blood, which is poor in oxygen, to red blood, which is rich in oxygen. The blood travels back to the heart and is sent to the rest of the body. But with pulmonary hypoplasia, there are fewer alveoli and blood vessels than necessary to provide the body with the oxygen-rich blood it needs. Pulmonary hypertension, which means high blood pressure in the lungs. Before a baby is born, it receives oxygen from its mother, not from its lungs. The baby's blood flows from its heart, bypasses the lungs, and flows to its body. This is possible because of special fetal connections that let the blood skip the lungs. After birth, these connections close. The blood now flows through the lungs, picks up oxygen, flows back to the heart, and out to the body. But with pulmonary hypertension, the blood vessels in the lungs are so small that pressure starts to build up. This pressure causes the fetal connections to remain open. After birth, blood continues to flow through the old fetal connections, bypassing the lungs, reducing the amount of oxygen delivered to the baby's body. The severity of this condition requires a comprehensive approach.
For unknown reasons, the diaphragm in some babies doesn't develop completely before birth, resulting in an opening between the chest and abdomen. The most common location for this opening is on the left side of the diaphragm near the back. The baby's abdominal organs can push through or herniate through this opening in the diaphragm and compress the lungs. As a result, the lungs do not develop fully, causing the baby to have significant trouble breathing right after birth. Before the operation, the baby will be given general anesthesia to put him or her to sleep for the entire operation. A breathing tube, inserted soon after birth through the nose or mouth and down the throat, will continue to help the baby breathe during the operation. Usually, the surgeon will make an incision under the ribs on the left side. Next, the surgeon will carefully move the
Recording in
hernias.
progress.
The most common is the Bochdalex hernia, which occurs in the posterolateral side of the diaphragm. This occurs in 80 to 90% of cases. The anterior defect is called the Morgagni hernia. Occurs in less than 2% of cases. You also have the one called hiatal hernia, but this one is more loosening of the crura, dun sa where the esophagus is inserted going down to the stomach. So it isn't exactly the same pathophysiology with the tawag dito, with the formation of your diaphragm, but it can also present as parang herniation through the diaphragm. So again, most common is your Bochdalek occurring posterolaterally. The management of these, the cause of these cases, 50 to 60% isolated, unknown, don't know whether there's genetic or a combination of genetic and environmental factors. As with a lot of our congenital anomalies, the cause is usually largely unknown, but it usually involves some form of mutation or an environmental insult. Around a small subset of cases are part of a syndrome, so around 10 to 15%. So these are the syndromes that usually involves congenital diaphragmatic hernia. For the management, the most important part and the first thing we need to do in these cases is cardiorespiratory stabilization. So as the video showed kanina, the presentation, the things that are involved in these cases are pulmonary hypertension, which is that the blood is backed up into the pulmonary veins, so causing the lower oxygen level circulating in the blood. The other possible problem in these cases is hypoplasia. I mentioned earlier, there is no development of the lung or very small lang yung lung because of the mass effect that the herniation has caused during fetal development. Hindi na nagdevelop yung lung at all. So in very severe cases, these may not be compatible with life. So we try and do cardiorespiratory stabilization first, see if the patient responds, because surgery will only close the defect and put the bowels back into the abdominal cavity, but surgery cannot create a lung. So if the lung didn't develop at all, if the hypoplasia is severe and the pulmonary hypertension is severe, surgery may not be helpful at all. So that's why 40 to 50% of these cases actually don't make it. So the more aggressive forms of ventilation, we do using high frequency oscillatory ventilation, or ECMO, extracorporeal membrane oxygenation, which is we divert the blood out of the body, oxygenate it outside of the body, and then pump it back into the body. So you can imagine that is not something that is sustainable. It can only be temporarily helpful for severe hypertension. So it's a very select few cases where these are done. The last part of this first part of the lecture would be on esophageal atresia and tracheoesophageal fistula. I'm again gonna show you a video on the presentation. Oops, it's not playing.
A tracheoesophageal fistula is a birth defect in which the esophagus has an abnormal connection to the trachea. The esophagus is the tube that food passes through from the mouth to the stomach, and the trachea is the windpipe that air passes through from the mouth and nose to the lungs. The trachea forms during the 6th week of pregnancy. Here you can see the tube that will eventually form all the organs of the digestive system. The trachea and lungs grow from the part of the digestive tube that will eventually become the esophagus. For unknown reasons, the esophagus and trachea may grow and separate abnormally during this time. The esophagus may end in a blind pouch with missing gaps and be abnormally narrow. This absence or narrowing of a natural body passageway is called atresia. The esophagus and trachea may also have an abnormal connection called a tracheoesophageal fistula. Here we see the most common type of tracheoesophageal fistula in a newborn infant. The upper esophagus ends in a blind pouch, and the lower esophagus connects to the trachea. This is a serious problem because stomach contents can travel up the esophagus and pass through the fistula into the trachea and lungs. The fistula can also cause difficulty breathing for the newborn, since air can now bypass the lungs and enter the stomach.
So these are the types of esophageal atresia with or without tracheoesophageal fistula. So as mentioned earlier, the most common type is there is a proximal esophageal atresia. You see the type C in the middle here. There's a proximal esophageal atresia and then a distal TEF, or tracheoesophageal fistula. So this is the one that causes backing up of your gastric fluid into your airways, which is dangerous. So this usually would require an emergency procedure to remove that fistula. But it can also present in other ways. 7.5% here in type A is an esophageal atresia without a TEF. So the problem with these cases are usually the gap is too long that we can't connect the proximal and distal esophagus together. But so that can occur. Type B, you see here, has a proximal TEF, and then it's the distal that is not connected. Your type D, both the proximal and distal esophagus, there is still a gap, but they are both connected to the trachea. And then finally, an H type can be present where there is no esophageal atresia. The esophagus is actually continuous, but there is a tracheoesophageal fistula. This is a type of DEF. The way we diagnose them, usually they present with respiratory distress at birth or excessive drooling. So if you swallow saliva and it goes nowhere, it doesn't go down to the stomach, it just pools into a pouch, and a blind end pouch in the esophagus. So you can imagine all the saliva is is drooling out of the mouth. We place a orogastric tube, which should go all the way down. The tip of that should go all the way down to the gastric bubble on X-ray. So when instead, in esophageal atresia, we see that the tube just loops up in that blind pouch in the proximal esophagus. So this X-ray is already diagnostic of esophageal atresia, and we are already. The fact that there's air in the stomach, it means that there is a distal tracheoesophageal fistula, because there's no other way for air to get into your stomach other than through a fistula, kasi nga hindi connected yung proximal esophagus with the distal part. Some patients, doctors would require esophagoscopy or esophagostomy, which would show your contrast pulling into that blind pouch. But that usually is no longer required, and it's a dangerous procedure because the patient can aspirate your contrast. So procedure involves thoracotomy, opening up the chest, looking for that TEF. It's very, very tiny. And then removing that connection from the lung. So that's the primary thing that we do. And then if the two ends could meet, we do a primary surgical repair. Sometimes it's too far apart that we cannot connect them together. In those cases, there are other procedures, other options that we do. We can do a staged procedure where we put traction sutures and then reoperate after a few days or weeks until the muscle is stretched enough that they can meet. in more severe cases, we don't even attempt to do a primary surgical connection of the esophagus. Instead, we just put a gastrostomy and feed through there. And then when they're much older, when they're maybe 2, 3 years old, we do replacement of the esophagus by pulling up the stomach or pulling up a part of the colon, making that like a makeshift esophagus so they can feed orally. Okay, so that's the first part of the lecture. Do you have any questions so far? I hope the videos are helping. Kasi mahirap i-imagine yung... hearts. Mahirap i-imagine yung embryology. I actually never fully understood embryology until I found YouTube videos. To let you know, the videos mostly are from Children's Hospital Colorado. Some of them are from Animated Embryology. So they're not mine. I did not make them, but I found them for you to help. Mahirap i-describe yung embryology part. Oh, there's more of you here now, 320. No questions so far? I'll go to the next one. The next one has a lot of videos, so I kind of recorded myself na lang. Okay, just speak anytime if you have a question. Because it's a lot. We're covering a lot of things. This is the second part of the lecture series under the pediatric surgery module. For this lecture, we will be discussing abdominal wall defects and umbilical remnant anomalies, including the vitelline duct and the urachus. In order to understand why abdominal wall defects and umbilical anomalies occur, we must first review how these structures are formed during fetal development. So during the 4th week of development, the embryo undergoes a process of rapid growth and embryonic folding in 2 planes. Seen here is folding in the median plane. This shows embryonic folding along the transverse or horizontal plane. Normal development of the abdominal wall depend on the resulting 2 lateral folds on the horizontal plane meeting together and fusing at the midline. And any defect or any failure during this process will thus result in an abdominal wall defect. We will be discussing the 2 kinds of or presentations of abdominal wall defects. Gastroschisis is the condition where eviscerated bowel through the wall defect has no covering membrane, while omphalocele is one where the eviscerated bowel is covered by a sac. The difference between the two are as follows. The defect size usually for gastroschisis is much smaller than that of an omphalocele. Omphalocele always have a sac, except sometimes they may be ruptured, while in gastroschisis these never present with a sac. Patients with gastroschisis usually are born premature, while those with omphalocele are usually brought to term. The umbilical cord in gastroschisis is usually to the left of the abdominal wall defect, while in omphalocele, this is continuous with the sac. The herniated viscera is usually the same for both, except for omphalocele. When the defect is large, the liver may be included in the herniated viscera. Bowel character for your gastroschisis is usually inflamed and edematous due to the exposure to the amniotic fluid, while in omphalocele it is normal because of the membrane covering. Associated anomalies are more common for your omphalocele. Specifically, the associated anomalies include cyanotic heart disease, clubfoot, and a condition called Beckwith-Wiedemann syndrome, wherein omphalocele is associated with microcephaly and macroglossia.
For gastroschisis, although uncommon, this may occur with intestinal atresia due to ischemia of the eviscerated bowel. Sometimes the skin is fused, but there is a defect in the fascia through which bowel can herniate through and cause bulging of the umbilicus when the baby is straining or crying. These cases usually resolve by themselves as the baby grows. Umbilical defects could also come from structures that are remnants of the umbilical cord. One of such structures is your vitelline duct. The vitelline duct, also called omphallomesenteric duct, acts as a communicating tract between the embryonic yolk sac and its primitive midgut during early fetal development. Now, during the development of the midgut, the cecal bud forms distal to the vitelline duct so that the vitelline duct would always be at your distal ileum. This structure normally obliterates around the 8th week of development. If it persists as a sinus connected to the umbilicus, it is called patent omphallomesenteric duct, and it appears as a fleshy mass with a sinus in the umbilicus that sometimes could excrete meconium-like material. This is managed by simple resection of the lesion with primary anastomosis of the ileum. If the vitelline duct obliterates but there persists mucosa in the umbilicus, then this could result into an umbilical polyp which can be managed with simple excision. Sometimes the distal portion of the vitelline duct obliterates but there persists a portion of it proximally that is still attached to the ileum. This results in the Meckel's diverticulum, which is an outpouching of your intestines in the distal ileum. This condition is often described in terms of the rule of twos, which is quite inaccurate, but it helps you remember the characteristics of Meckel's diverticulum. First, that it affects around 2% of the population, although very little portion of this will actually end up symptomatic, and those asymptomatic will not need management. The symptoms usually occur during the first 2 years of life, and it is always located at the distal ileum. Finally, there are two types of ectopic epithelium that could occur in the diverticulum: gastric epithelium and pancreatic epithelium. And the presence of gastric epithelium or mucosa could appear on your Meckel scan and is usually the cause for gastrointestinal bleeding in those cases. Another possible presentation of the remnant of your vitelline duct is a persistence of a fibrous cord connecting your distal ileum with the umbilicus. And finally, your vitelline duct could obliterate proximally and distally, but have some mucosa persisting in the middle that could result in an omphallomesenteric cyst. All these cases then can present in a number of different ways. First, especially if there is the presence of gastric epithelium, the lesion could present as gastrointestinal bleeding. Another presentation is obstruction, since the small bowel is highly mobile and this connection could result in twisting of the small bowel. Finally, the lesions can present as a sinus or a cyst. The next set of umbilical remnant anomalies is your urachal remnant. Now, during development, the allantois is an endodermal-lined ventral outpocketing of the hindgut. This one is a respiratory organ, and it is highly vascular, supplying oxygen to the growing embryo. The proximal part of the allantois is continuous with the forming urinary bladder. After birth, normally it becomes a dense fibrous cord, now called median umbilical ligament, that runs from the urinary bladder up to your umbilical region. So if this remains patent, your umbilicus would have a connection to the bladder, seen here on fistulogram. Upon introduction of contrast to the umbilical lesion, the contrast shows to light up the bladder. If you notice, the gross appearance of your patent urachus and patent omphallomesenteric duct are very similar, and the only way to differentiate the two is through fistulogram, which in patent omphallomesenteric duct would light up the small bowel instead of the bladder. However, management is similar, which is umbilical dissection and repair of the affected organ. And hopefully by now you can differentiate the different abdominal wall defects and umbilical anomalies. Thank you for listening.
Can you identify those last four? Let's go back to that one. So shout out na lang, anyone who can identify. Letter A, what is the diagnosis? Oh no,
Omphalocele.
250 students.
Phallosil po.
Omphalocele, yes. B?
Gastroschisis.
Gastroschisis, yes. C? Anybody? Letter C? Bulging of the umbilicus.
Umbilical hernia.
Umbilical hernia, okay. So for those three conditions, the primary treatment is closure. We just close the fascia, close the skin if we can. So there are certain conditions, certain instances, especially with omphalocele, where the defect is too big na we can't fit the contents in the abdominal cavity, meaning hindi large enough yung abdominal cavity to fit all of that. And if we push it too far, it can cause abdominal compartment syndrome. So in those cases, sometimes we are unable to put it back, and that sac can actually epithelialize and become skin. So ang mangyayari, parang may pouch siyang nakalabas, parang hinayaan natin magkaroon ng umbilical hernia. And then later on in life, when they're much bigger, that's when we do the aesthetic repair. So closure of all of these conditions is the treatment, the surgical treatment. And then for letter D, so this is either your patent ophalomesenteric duct or your patent urachus. So we do umbilical exploration. We look at where this is connected to. Is it connected to the bladder or the bowel? We remove it from the umbilicus, excise that lesion, and then close the defect on either the bowel or the bladder. Okay, are we still good so far? Any questions? Last na. Kaya pa? Last na. Ang daming cases. So much to study. So the last part of the lecture is on GIT conditions. For your exams, I would suggest that you stick to what we've discussed here in the lecture. Memorize. Understand is better than memorizing, because we give a lot of cases and then you identify the diagnosis or the treatment or the next diagnostic. So now in the age of AI, hindi na masyado, we give a very little now of recall questions and memorization, but when we give you a case, there are certain characteristics of these diseases, like for example sa neck mass, i-describe naman kung centrally locating, laterally locating, where exactly, and then what are the associated things with it, how the mass is described. So like for example, centrally locating, movement with tongue protrusion, that would be thyroglossal duct cyst. Yun yung mga clues that you see on your exam questions so that you can answer them. So when you study these things, memorization is not enough. You have to understand. So I hope these videos are helping you do that. I'm just chatting in case may question. And if none, I'm going to the next one.
This is the third part of the lecture series in the pediatric surgery module. For this lecture, we will be discussing congenital and acquired gastrointestinal disorders in newborns and infants, starting with the condition known as malrotation. This occurs when there is a defect in the normal rotation and fixation of the midgut during embryonic development. 4 important stages of midgut development should occur: herniation into the umbilical coelom, rotation, retraction back into the abdominal cavity, and finally fixation. It is also important to note where the areas of the gastrointestinal tract is derived from, because it also dictates the arterial supply and normal development. During the sixth week of development, the midgut forms a U-shaped loop and herniates into the umbilical coelom. As it does this, it rotates 90 degrees counterclockwise around the axis of the superior mesenteric artery. During this period, it elongates and differentiates into the segments of the small bowel and proximal colon. Around the 10th week, it retracts back into the abdomen, and the small bowel returning first. As the large intestine then retracts, it rotates an additional 180 degrees counterclockwise, ending up with the duodenojejunal junction fixed by the ligament of Treitz, and then the descending colon fixed to the left side and the ascending colon to the right side. If there is failure of the normal intestinal 270-degree counterclockwise rotation, then this results in non-rotation, ending up with the duodenojejunal limb on the right and your cecocolic limb on the left side. On the other hand, if there is an arrest of rotation at or near 180 degrees, this usually results in peritoneal bands that are obstructing, connecting the right side of the peritoneum to your cecum, otherwise known as Ladd's bands. The cecum is usually located on the right upper quadrant. A more rare kind of malrotation is called reverse rotation, in which rotation occurs in a clockwise manner rather than counterclockwise. In these cases, the duodenojejunal loop ends up anterior to the SMA, and then your transverse colon ends up posterior to the mesenteric artery, which then causes obstruction, compressing on your colon. These cases can usually be identified through abdominal X-ray, presenting as a distended stomach with paucity of gas in the small and large intestines. It can also be identified through upper gastrointestinal series, which normally should show your duodenojejunal limb crossing the midline. So in cases of malrotation, instead of crossing the midline, your duodenojejunal junction is seen to be displaced to the right side. Other signs on gastrointestinal series would show beaking of the duodenum, and in cases of volvulus, there could be a corkscrew sign. The condition can also be seen on contrast enema to show as displacement of your cecum on the right upper quadrant or the left upper quadrant. Management of these cases is called Ladd's procedure, which is comprised of detorsion of the volvulus, division of Ladd's bands, and then widening or broadening of the small bowel mesentery. The next condition is called hypertrophic pyloric stenosis. As the name suggests, hypertrophy means to increase in size of your pyloric muscles, which causes narrowing or stenosis at the area connecting your stomach to your duodenum. Usually, these patients have a normal pylorus at birth, and after around 2 to 6 weeks, pyloric hypertrophy and hyperplasia occurs, which on physical exam can be felt as an olive-like mass on the right upper quadrant or epigastric area, and the most common presentation is non-bilous vomiting, which intensifies as the patient feeds. This non-bilous vomiting results in losses of gastric fluid, which is high in your hydrochloric acid and your potassium. Losses in your hydrochloric acid would deplete your chloride stores and result in hypochloremia. Dehydration from fluid losses will then stimulate your kidneys to retain fluid by retaining sodium in exchange for your potassium. This, along with losses in your gastric potassium, will result in hypokalemia. Hypokalemia, in turn, will stimulate your kidneys to retain bicarbonate, which incidentally is also stimulated by dehydration. So hypokalemia then will stimulate your hydrogen ions to migrate to the intracellular compartment and also stimulate hydrogen secretion. All these combined will result in the characteristic hypochloremic, hypokalemic, metabolic alkalosis, which is seen in patients with hypertrophic pyloric stenosis. On X-ray, it could appear as a gastric distension with paucity of gas in the small and large bowel. More definitively, it's seen on upper GI series as a string sign in the area of the stenotic pylorus, and the ultrasound can show the pyloric thickening. Management is done first by correction of your fluid and electrolyte imbalances. Then more definitive management would be surgically by doing either pyloromyotomy or pyloroplasty. The next condition we will talk about is intestinal atresia. Atresia means the absence or narrowing of a natural body passageway, meaning atresia could occur in any portion of your gastrointestinal tract that has a lumen. In the case of your duodenum, duodenal atresia usually occurs around the second portion of the duodenum. And this can present in several types. It can present as a membrane or as a web in type 1. In type 2, the lumen is completely obliterated, but the proximal and distal portions of the duodenum is still connected by a fibrous cord. In type 3, there is no connection between the proximal and distal portion of the duodenum, and both type 2 and 3 may be associated with an annular pancreas. The condition can be diagnosed on prenatal ultrasound or by abdominal X-ray upon birth, showing a double bubble sign. The first bubble is your gastric bubble, and the second one is the first portion of the duodenum, divided in the middle by the pylorus. Jejunal and ileal atresia can also present in several forms. The first is stenosis. Type 1 would be a web. In type 2, the proximal and distal segments of the atretic portion is still connected by a fibrous cord, while on type 3, the proximal and distal portions of the atretic bowel are completely disconnected with a mesenteric defect. And in more severe forms, this can appear as an apple peel appearance. Finally, type 4 is presented as multiple atresias. On abdominal X-ray, this would show as bowel obstruction depending on where the atresia is located. Definitive management is surgical repair to create continuity of the bowel lumen, and this is done through anastomosis of the proximal and distal segments. The next condition is called Hirschsprung's disease.
Hirschsprung disease is when a baby is born with intestines that can't move stool out of the body. This is because part of the intestine is missing its nerve cells, called ganglion cells, which keeps the intestine from working normally. Hirschsprung disease is fairly common, affecting about 1 in 5,000, and is more common in boys than girls. About 20% of cases occur within families, so it may be genetic. As a baby grows, ganglion cells migrate down the small intestine and colon. These ganglion cells trigger a series of contractions and expansions called peristalsis that help move food through the intestines. But in Hirschsprung disease, the ganglion cells don't migrate down all the way, leaving an area without any ganglion cells, which is called an aganglionic area. This has two effects. First, the aganglionic area and the anal canal are unable to relax. This means that they are much stronger than they should be, and create a high amount of pressure. And second, the peristalsis in the healthy area can't overcome this pressure to move stool out of the body. Usually, this only affects the lower end of the colon, but in rare cases, it can affect the whole colon, or in extreme cases, even the small intestine. After the baby is born, stool starts to build up, and the stomach may become very large. The colon responds by becoming swollen and painful, which is called colitis. This leads to the following cycle. First, the aganglionic colon and the anal canal become blocked. Next, stool and gas build up. This allows bacteria to grow to abnormal levels. This makes the colon flare up, known as colitis, becoming painful and swollen and can't absorb as much water and nutrients. This further weakens the healthy colon, which puts less pressure on the anal canal, which continues the cycle. Symptoms of this cycle include decreased peristalsis, an enlarged abdomen, liquid stool, fever, dehydration, abdominal pain, nausea, vomiting, and stunted growth. The first and most effective way to treat colitis is by a colorectal irrigation, which clears the colon out with water. This breaks the cycle and allows the baby to recover from colitis before surgery. Even though irrigations can help manage colitis, Hirschsprung's disease is life-threatening if left untreated and must be fixed by surgery. The goal of the surgery is to unblock the colon and preserve bowel control. This is done by removing the aganglionic area while protecting the anal canal. The first cut is made just beyond the affected area. This includes the rectosigmoid, the body's natural reservoir for stool. Without this reservoir, bowel movements may be faster than they normally would be. Next, the second cut is made in the rectum, just above the anal canal. It is critical that this cut is made 2 centimeters above an area called the pectinate zone. If cuts are made through this zone, it can damage the anal canal. This can result in fecal incontinence, and the child will not be able to control their bowel movements. Since fecal incontinence is irreparable, irreversible, but most importantly preventable, it is critical that surgeons protect the anal canal. After this cut, the aganglionic area is removed. Finally, the healthy intestine is connected to the rectum, restoring peristalsis. Even if the procedure is done correctly, 30% of patients will still have flare-ups of colitis. This is because the anal canal is still stronger than the healthy colon at first. Irrigations are still needed to stop stool from building up until the healthy colon gets strong enough to overcome the pressure of the anal canal. This can take months to even years and varies widely from person to person, but the severity and frequency of colitis and irrigations should decrease as your child grows.
The gold standard for definitive diagnosis of Hirschsprung's disease is to do a full-thickness rectal biopsy. And diagnosis is made if there is an absence of ganglion cells in both the myenteric and submucosal plexuses. Contrast enema is also usually done, in order to identify where the transition zone between the aganglionic and ganglionic portion of the bowel is. And the most common area for this transition zone is the rectus sigmoid area. Next, we have the imperforate anus.
An anorectal malformation happens when the anus, rectum, and other organs do not develop properly during pregnancy. This affects the child's ability to have bowel movements. The anus is the opening at the end of the rectum where sphincter muscles help control bowel movements. The colon, rectum, and anus work together to move stool out of the body. During a bowel movement, stool passes from the colon to the rectum and then out the anus. But when a child has an anorectal malformation, stool can't leave the body until surgically corrected. Each child's malformation is unique and can range from mild to severe. In mild cases, the opening may be too narrow and in the wrong place. Usually these children can have voluntary bowel control after surgery. In moderate cases, it may not be present at all, preventing a baby from having a bowel movement. In more severe cases, the rectum opens into the urinary or genitourinary tracts, which can cause a urinary tract infection. Some of these children may not achieve normal bowel control. An anorectal malformation affects girls the same way as boys. The rectum can be in the wrong place, missing, or connected to the genitourinary tracts. Some children may only need one operation to correct the malformation, but most need 3. The first operation is a colostomy. The surgeon splits the colon into 2 and brings each end through the abdominal wall, forming 2 openings. This allows the stool to temporarily pass into a bag outside of the body. A few weeks later, surgeons use the PSARP or Pena procedure to place the anus in the correct location. They start by removing the connection with the urinary or genital tract and pulling the rectum through the center of the sphincter muscles to connect it to the anus. This forms a new path for stool to leave the body and allows the child to use the sphincter muscles in the anus. The final operation is completed about 2 months later once the child has healed. During this operation, the colostomy bag is removed and the surgeon reconnects the 2 ends of the colon. After this final surgery, the child is able to have a bowel movement.
The most common presentation of imperforate anus in males is that with rectourethral fistula, while in females it's usually associated with rectovestibular fistula. Although already diagnosed by physical exam, we usually do an X-ray with the patient in prone position and the buttocks elevated to see where the rectal pouch ends and how far it is from where the anal opening should be. This would help us determine whether the patient would need a single operation or a colostomy. We also need to do workup for any associated anomalies, and commonly with imperforate anus, we could find the Vactor-L syndrome, which is composed of vertebral anomalies, anorectal malformation, your cardiac anomalies, tracheoesophageal anomalies such as a fistula, and esophageal atresia, renal anomalies, and your limb anomalies. The next condition is an acquired condition called necrotizing enterocolitis. This is the inflammation and coagulation necrosis of the bowel wall, which can occur in a single segment or multiple segments of the bowel. It is usually multifactorial, but more commonly, it is due to unfavorable balance between commensal and pathogenic bacteria. It is also commonly associated with inappropriate response of an immature immune system. So what occurs is there is a disruption of the intestinal barrier, which then results in bacterial translocation to the bowel wall. This results in further weakening of the bowel wall and sometimes hemorrhagic necrosis. It commonly occurs around 2 weeks of age when bacterial proliferation occurs in the bowel lumen and is more common in preterm neonates. The most common clinical presentation is abdominal distension, followed by either gross or occult blood in the stool. The patients can also present with vomiting or feeding intolerance, and in very severe cases, peritonitis. Diagnosis and staging of the severity of the disease depends on the clinical, radiographic, and gastrointestinal findings. And the management depends on the severity of the disease, which is usually managed mostly medically, although around 20 to 40% may require surgical intervention. The next condition is called intussusception. This is when a portion of the bowel telescopes into itself, and the most common part involved is usually the ileocecal region. The classic clinical presentation is intermittent crampy abdominal pain associated with current jelly or bloody mucoid stools. Sometimes there's a palpable abdominal mass where the intussusception is. The most common age of presentation is around 5 to 11 months, and the cause is usually idiopathic, although sometimes it's caused by lymphoid hyperplasia from an infection in other parts of the body. In older children, there is usually a lead point, meaning a polyp or a mass in the bowel that causes the intussusception. On abdominal x-ray, this can be seen as a target sign and small bowel obstruction. However, the target sign can better be visualized through abdominal ultrasound. Barium enema would show a meniscus sign where the intussusceptum is, and this actually could be both diagnostic and therapeutic, as management of intussusception could be done by non-operative reduction. This video shows pneumatic reduction of intussusception using air pushed into the rectum and then using that increased air pressure in the bowel wall to push that intussusceptum back through the ileocecal valve. So you would know that the intussusception has been successfully reduced when there's air passing through the ileocecal valve and into the small bowel. If this is unsuccessful, or if the patient has a high risk for perforation, then operative management would be done. Operative manual reduction of bowel is seen here on the video, and you would have to check after reducing it if the bowel is viable or if it's already gangrenous, in which case a resection of the gangrenous bowel segments would need to be done. So that ends the lecture for today. Thank you for listening.
Okay, we have one question. Reference for pediatric surgery, Ashcraft, Justin. Can I see everyone? That's the last one. That's the last one. Ang bigat, mabigat yung lecture. But that's the last one. I hope the videos help. These lectures are available on YouTube, but you cannot search them. They are unlisted, but I uploaded them on YouTube for you. So you can go back to them because it's a lot. I know that it's a lot. Akala ko pa naman may question. Reference pala, Ashcraft. Ashcraft. I'll show you. But it's a lot to read. I know you're reading a lot of things all at the same time. This is the latest version of Ashcraft. I'll show you. Holcomb and Ashcraft. This guy. I'm sure it's in your pirated sites. I know you have pirated sites that you go to. This is most likely there. But for the purposes, for your level, for the purposes of your exam, a lecture is enough. If you understand the lecture. Like for example, I give the exam asks for diagnosis for a 6-month-old with current jelly stools, palpable abdominal mass, and obstruction, vomiting, abdominal distension. It's the last case, diba? Intussusception. If you have current jelly stools, intussusception agad yon. So if you just have to understand what happens. Do we need to study detail modified bells better? Yes. Sabi ko sa inyo, ang nilagay ko sa lecture must know. I did not put unnecessary things. I did not give you highfalutin theories on the genetic causes for these conditions because those are nice to know, not needed for a clinician. The modified Bell staging for necrotizing enterocolitis kasi it's how you diagnose and manage. It has both there. So it kind of summarizes a lot of what you need to know with necrotizing enterocolitis. You diagnose radiologically and clinically. The reason why we have those tables, those classifications, those staging, is that they aid or they help you determine the management. So you should know those things. Any more questions? Pinaghirapan ko yun ah. I will, if you have a leader of the group, I can send you the link to the